I'm Linnea Lindsay. I'm a clinical psychologist and I do mostly consulting, private practice kind of things these days.
Welcome. I see Francis next.
Sure, thanks. It's hard to know who goes next. I'm Frances Robbins. I'm a psychiatric mental health nurse practitioner, and I'm one of the owners of New Start Psychiatry, an outpatient mental health clinic.
Great, welcome. And then I see Sheldon Levy.
Hi, I'm Sheldon. I'm a clinical psychologist. I'm a adjunct faculty in the Department of Family Medicine and also the Department of Psychiatry at OHSU.
Welcome. Kathy?
Kathy Savicki, retired clinical social worker, was with Mid Valley Behavior Care Network before it went away.
Gary?
Good afternoon, everybody. Gary Cobb. I use he, him, his pronouns. I have a consulting company and just several contracts, but one that's really relevant for this work is I'm working with the University of Oregon's Center for Brain Injury Research and Training, trying to develop a traumatic brain injury screening process for the state. And so I'm pretty excited to eventually talk about how we can fit this into some of the work that we talk about here. Thank you.
Okay. Ryan?
Hello, I'm Ryan Bear. I'm a social worker. I work for All Care Health in Southern Oregon.
Adrian?
Hello, I'm Adrienne Oxier. I'm a licensed professional counselor and I'm the Quality Systems Director at Kairos.
Great, thank you. Yvonne?
Hi, I'm Yvonne Hubbard, and I am the Billing and Compliance Manager at Oregon Community Programs. And I'm interested in the discussions today on the behavioral health and code pairing questions and the benefit update project orientation and coding changes.
Great, welcome. Sandy?
Hi, so I'm Sandy Cook, and I am the Coding and Revenue Cycle Support Manager at Trillium Family Services. And so I'm just listening in to see if I can learn anything.
Great, welcome. I forgot to introduce myself. My name's Ariel Smits. I'm the Medical Director of the Health Evidence Review Commission. And for the record and for anyone who's here, this is the Behavioral Health Advisory Panel. Jason Gingrich, you can wave. He's our director. And it looks like Jessica has dropped off already. She's our admin support, but I know she had to leave.
I'm still here.
Oh, it's your cat. I didn't see
my cat. It's my cat, so it is memorable.
Yes.
It's a wonderful cat.
Thank
Everybody
you.
should have a cat like that.
He's a lot bigger now, but you can't say no to that little face.
And Jessica's here helping out with all of our tech support that I can't do. So welcome. Just to remind you all, the Behavioral Health Advisory Panel is a group that we get together to advise HERC staff on different behavioral and substance use disorder topics. And then we will, anything that's discussed here, there's no final decisions. We will bring this to the next HERC meeting, the Value-Based Benefits Committee, and then the HERC meeting, which is, it's next week. So if there's if we get stuff to them as a handout, they might approve it. Otherwise, we'll discuss it in November, which is more likely. And you all are welcome to come to that meeting. They're all open public meetings, and we are happy to have you. Oh, a new grandbaby with a new Ariel. That's so sweet. All right. Anything else just for background or anything, Jason?
No, I'll save the news for the the benefit update project.
Yeah. I know you guys are eager to hear about that. You should have gotten materials about a week ago. We usually have this meeting in the fall because of the new CPT codes that come out. There's usually something behavioral health related. When I initially had everything set up for this meeting, I didn't see anything behavioral health related, but as of working on the codes, I want to, so I'm changing the agenda just a teeny bit. I just want a quick open question to you all. And this is not any materials that you received. This is just basically putting you all on the spot question. There are a series of new CPT codes for serum or CSF tests for amyloid and tau proteins, which is a way to diagnose Alzheimer's. Does anyone have any familiarity with that? Anyone know of anyone? I see Lindsay raising, or I'm sorry, Linnea raising your hand.
You just said, does anybody have any familiarity? So yes.
Okay. Yeah, it looks like it's one of those like rapidly moving areas in science, and I'm trying to catch up rapidly. We're doing an evidence review, but I was hoping I might be able to pick one of your brains, but all right, hearing none, we will move on to what's on our actual agenda. Does anyone have any concerns about the highlights from last year's meeting? I know they're just highlights, they're not official minutes. We don't have to approve them or anything, but did anyone have any questions or concerns?
I do think we need to call this meeting to order.
Oh, yes, thank you.
Yes, I will call it to order.
Thank you. Okay, now this is you're officially called to order. So there were a lot of code pairings that I was kind of bringing to you all that should have been in your materials that you all saw. So this mainly comes from what we call the non-pairing file. HERC staff get this a few times a year where codes, diagnoses, treatment codes that are being denied by the computer systems as not pairing will come. And I tried to pull a whole bunch of those that looked like they'd been coming a lot to see if this was something that we want to consider doing any changes on. And so it ended up trying to put them in two different buckets. One was more behavioral health, one was more substance use. So the first one, actually, which came first in your packet? Was it the behavioral health or the SUD?
The
Behavioral health, I think.
Okay.
No?
No, it's the SUD 2.1A. I'll put it up on the screen here now.
Yeah.
Sorry, I
So
take things from a different way from the folder than you guys get in your packets. So I apologize. So the first one, the substance use disorder line review, there were multiple different kinds of pairings. Just giving you a reminder of which lines these are. It's mostly substance use disorder, as well as we have a couple of substance use, mood, and delirium types of things, as well as abuse of non-addictive substances. I kind of made a table and wanted your input. So it should be the next page up, Jason, going down to page 2. You'll start to see a whole bunch of codes, and then the code description, the current lines, and then where we were seeing that there were claims, diagnoses that we were seeing a lot of denied claims for. If that fourth column is blank, we didn't see denied claims. We're just kind of trying to put the whole code series there for your, just so you can kind of keep almost, kind of know where we are in the coding book. So how do you want to approach this? Do you want to just kind of take them one at a time?
I have a suggestion, because we are looking primarily at 62 and 65 and maybe a little bit else. I think it would be good for us to have an overview of what each of those lines really means, what the diagnostic kind of clarification is there, because I think differentiating it, why 4 and 62 and 65 are different from each other, and why you might include some and not include others, is important.
That's a great question. So 4 is for complicated, in remission, etc. It's substance use disorder. Then there are 62 is substance use disorders that are also accompanied by mood disorders.
Substance-induced mood disorders, right?
Substance-induced mood disorder. So yeah,
Yeah.
so you don't have coexisting depression. You have depression or anxiety caused by your substance use. And then 65 is intoxication and withdrawal. And I think that's where we're getting a lot of the code non-pairings. So somebody will come into the emergency room intoxicated or in withdrawal, and they end up in a treatment program. And we wouldn't necessarily want them to go through a treatment program while they are acutely intoxicated or in withdrawal, but that would be a short-lived state, and then their substance use would be treated. So some of this might be just coding conventions, some of this might not be. As you'll hear later, we are looking at doing quite an extensive review of everything below the line. If you feel like some of these substance use lines are kind of artificially separated and we should put them together, I mean, that's definitely something that we can do as we're kind of looking at the whole prioritized list a little more closely.
If I may, also, I think line 65 used to be in the medical as opposed to the MHO world back in the day.
I believe you're right.
Include more of the medical system than the behavioral health system, but now we live in a world of integration, so it's a little bit muddier.
But that's why I was wanting us to be clear that line 4 is substance use disorder, or 62 and 65 are substance induced, and so I just think that having diagnostic clarity gives us clarity then about why we might pair a code with it or not pair a code with it. I don't know. Kathy, I always defer to you as well. You're super good at this, but I think that we've had this conversation in the last 5 years for some reason.
Yeah, this is Kathy. I think one of the issues may be that if somebody starts with a substance-induced delirium, for instance, and then moves into ongoing treatment, if the provider doesn't shift the diagnosis, that's where you're getting things not pairing. And it may be just a matter of getting diagnostic clarity as things change over time.
And I appreciate, Mitch, your comment too. I mean, I've been doing dual diagnosis work for a couple decades, and Kathy has too. I think that's the issue sometimes, is people don't change diagnoses. And so then they get it unpaired, like they're stuck with, and that may have to do with their EHR or based on when the person saw a diagnosing or provider, that kind of thing. But that's been my experience over time.
And that, just looking at this series, that appears to be what's happening. These are like residential treatment programs, community wraparound services, subacute counseling, which wouldn't be for somebody who's acutely intoxicated or acutely withdrawing, but would be appropriate as they're progressing down their treatment pathway. Gary, you have your hand raised.
Yeah, I think I was just thinking about that scenario where, and I'm just going to use my own personal experience. When I went to detox, I was in pretty bad shape and had a lot of, substance use, anxiety, mood disorder, all that stuff. And then as I got stabilized and went on to the next pathway, so detox settings, and I think it is mentioned here. So I think that's where you get the pairings at.
And I would agree with that. So there are some places where it really would be good. But if you look at H0011, like it's already paired at 4, 62, and 65. But why is H0012 typically in a subacute detox? You don't have that, but you could, because it's typically what you see in acute detox, not in subacute. But you can have some sequela of delirium, a kind of anxiety concerns. The question is, are they diagnosed separately, or are they considered substance induced? that differential diagnosis may or may not happen in those first couple of weeks of treatment because people are still kind of stabilizing. I think you're right. So I do think you can look at it, slice and dice it both ways. That was just a part of my thinking. It was important for us to understand that 62 and 65 were more about induced, rather, substance induced concerns rather than a separate diagnosis.
Okay. So just kind of starting with the GO 177, which is training and educational services relating to their disabling mental health problems. Would that be appropriate for substance use, or is that because that's on the behavioral health, but not the substance use lines?
So I think this gets into when you're parsing words. If seriously, disabling mental health problems. This has been our trouble. Are we mental health? Are we substance use? Are we behavioral health? What's the clarity there? I think the question is, are there other G codes that are paired with line 4 already that cover this? Because that's the other thing. We lived in this world where your substance use and your mental health were kind of separate from each other. So sometimes there's another HCPC that was already paired that was training and education. So I don't know. I didn't look at that.
I'm trying to
I'd
pull
have
up
the
line
same
4.
question, Linnea. I'm wondering what the code is that's been used historically in substance abuse programs that covers this same set of functions. And it's just a matter of they've had a code set that's been different than the mental health code set.
I'm looking at, so they have H0004 behavioral health counseling per 15 minutes. We're looking at,
Well, it depends upon who that's paired with. So training and education is not necessarily a therapist. I don't think the G0177 type of practitioners are the same as what you'd see for an H0004, but I may be wrong.
yeah, so so the GO177, they have, most of the G codes are like professional services, prolonged hospital, follow-up consult, group psychotherapy. Um,
I don't see education codes on that.
yeah.
Well, traditional substance abuse disorder treatment is heavy on the education, used to be primarily provided in a group setting, but there was also done individually. And there's got to be codes they've used for that. I just don't remember what they are.
Okay.
I see that the residential code H0015 includes education.
But there's an outpatient code too.
Mm-hmm.
There it is, H0016. Description of that. No, it doesn't include education.
So I don't see that we create any problems if we pair 117 with the substance abuse line. I don't think it creates any trouble.
Okay. Maybe that might be
and it might make it easier to manage in a more integrated program than using just the substance abuse codes.
maybe that would be a good place to start. Do any of you object to any of the additional lines? Are any of these something that you would say, oh no, that is definitely not appropriate?
So I want to go back to talking about, before we go down that, the GO177 is currently paired with a type of practitioner that can provide it: certified peer wellness specialists, QMHAs, QMHPs, psychologists, LCSW, LMFT, LPC. So it would seem like if peers can bill that code, but we are not allowing it because we're not tying it to substance use disorder, I think that has merit. So that's the other part of the matrices that I think about is who are the practitioner types that are tied to a particular code. And if the peer and wellness folks are already there, then that makes sense.
Are you looking at the fee schedule? Are you asking us to, or?
No, I'm looking at it. I pulled it up.
Okay.
And I'm saying it already lists under G0177 peers and peer wellness and peer support specialists. So a lot of peers do work in the substance use disorder.
Yeah, that seems like an important place for them to.
So then I think we need to tie it to line 4, clearly the substance use disorder, because that would be a missing piece.
Okay, great. And then there's the delirium, intoxication, and withdrawal. I think traditionally, as Jason was saying, this was a medical line, until you were stabilized and then you were handed off to the behavioral health silo. We could add the 65. We could just tell people that they need to bill something that's not acute withdrawal. Oh, Jason, your screen's flicking around everywhere.
Sorry, I'm trying to clean it up. Sorry.
I think I would suggest just keeping it the way it is. I don't know that you need to add 65.
Okay.
You're typically not doing therapeutic intervention with somebody who's that altered.
I did not think so, but okay. So, oops.
And I'd say the same is true for group counseling at that point.
Yeah,
but maybe case management. H0006. What do you think, Linnea?
Well, case management is usually done in tandem with the person as they're looking forward to, like, what are they, arranging. But maybe there is some arranging that needs to happen. That's case management. So yeah, I think that makes sense.
So I'm sorry. So H004, we are not adding to 65?
Correct.
4 and 5 we're not. 6 we are.
Okay.
And I think more people can jump in.
And then the residential treatments, I guess they would be a difficult. Oh, I think I see like H0017 is for not alcohol and drugs, and then you get down to the H2035, and then you get the alcohol and drug treatments.
So what are we doing with these?
Well, obviously 10.
I have a note
11.
to add the 12 to 62 and 65.
I would support that. Others?
I agree.
Yeah.
I agree as well.
Okay, and we're good with 15. It's also on the non-addictive substances.
So I am thinking the behavioral health ones we shouldn't add the SUD lines, and because they'd have their own residential treatment codes. Does anyone want to argue otherwise? Okay. And what about assertive community treatment? Is that something used in substance use? Because it's on the behavioral health lines, but not the substance use lines.
Well, there may be a lot of people being served in there that have dual disorders, but there's got to be a primary serious mental health condition.
Yeah.
Okay, perfect. And same with the skills training.
I was going to look at that one a little bit further. I think skills training again includes currently certified peer support wellness specialists. I think it could be included.
Included on which?
It's already on 4, so we could add it to 62 and 65.
Well, I don't know that you would add it to 62 or 65. I would leave it at 4.
Okay.
Got to be out of that acute phase, right?
Yeah, I think so.
Where you can learn much. Yeah.
Mm-hmm.
Okay. And the community wraparound services.
Kathy, what do you think about adding 4?
I don't know anything in the literature that uses a formal wraparound process for substance use only.
I was having trouble with that too. And it's not like you're going to teach people. I mean, you're not going to immerse them in a community setting, except for therapeutically, and you would have a therapist involved. So I think you could just leave it where it is without.
Yeah, I think so. Because you'd have a primary mental health diagnosis.
Yes.
And then what about alcohol and drug treatment programs for the substance use induced mood or the acute intoxication withdrawal? Or do we want them to have something that would be on line 4?
I would think that they need to have a diagnosis, actually, not just the intoxication or withdrawal phase, because they're in a program by then. And that's a per hour per diem. Yeah.
Perfect. Thank you. It's just nice to have you all sort of look at these, because I know that we can see that they're not pairing, but that doesn't necessarily mean that they should pair. So the only ones that I have were on the ones on the first page. We had 3 codes that we'll bring forward: the G0177 to add to line 4, the H006 to add to line 65, and the H0012 to 62 and 65. Great, thank you. Any other thoughts on that?
It looks like Yvonne had a comment.
Yes, Yvonne?
Yes, thank you. I was wondering if this was the right meeting to bring the introduction of another code when we were talking about the educational piece. There is another code that exists out there, H2027, is psychoeducational services. And while Medicare doesn't currently pay for this code, Medicare also doesn't pay for H2032, but Oregon Medicaid does pay for H2032, which is a skills training group. And so that's a widely used code.
What was the code again?
So H2027 is psychoeducational services. It involves teaching individuals about their mental health conditions and providing them with coping strategies and skills to manage systems. The sessions often include education on mental health, stress management, problem-solving techniques, and emotional regulation.
We have that code on all of our psychotherapy lines.
But not SUD though.
Not SUD and not mental health outpatient. It's not on either. And
it's just on the severe.
Yeah, and so I wanted to discuss bringing it forward if this was the right venue, bringing it forward.
It's on a lot of these are outpatient lines: anxiety disorder, panic disorder, feeding and eating disorders of infancy. Probably don't need it there. Our ADHD,
adjustment disorder.
Yeah. It's just not in here for the SED, and it might be on the behavioral health on the lines, but it's certainly not a code that's on the fee schedule that they pay for mental health outpatient.
Okay.
And that's a different area. So the HERC can say we should pay for it, but there's a lot of rules that are above us in terms of like if Medicare doesn't have a code open, we can't pay a percentage of Medicare, and we can't there's a lot of problems
Right.
at that
Yeah.
point.
And then so that's why I brought up H2032, because what the rationale that was provided to me was, well, Medicare doesn't pay for H2027. And I said, well, they don't pay for H2032 either. However, Medicaid does all across the board pay for H2032. So just sort of, pushing back sort of on that rationale is that if Medicaid can consider H2032 and they do pay for it, even though Medicare doesn't pay for it, might that open the door for the discussion of H2027? So, but I just didn't see the H2027 here on these behavioral health lines. And so I was wondering, I just wanted to see if this was the right place to introduce the H2027 for SED.
What do others think? And maybe we can talk to our colleagues about it. What do others on the call? Others support that? Anybody disagree?
I think it's a Q hawk, and I mean, I think it's a discussion, but it is an issue of how many codes do we add that we don't get to line up with the Medicare. There's some that there's been exceptions, but I think the idea was not to kick the barn door too far open, because the ability to get matching funds or to draw down funds. I think activity therapy was something unique enough, which is the H2032 that was being referenced, but I don't know that psychoeducational services was unique enough for us to add at any point.
Yvonne, what we can do is we can bring this over to our Medicaid sort of technical people and see, what the barriers are and see if there's any input on that.
Sure, thank you. I appreciate that.
And the answer might be we can't open it for some technical reason or not.
Mm-hmm.
Right. No, I appreciate that. I just wasn't sure if this was the correct venue to bring this up. But just once we started talking about the activity, it rang a bell in my mind. I was like, oh yes, there's this other, education service that I've always been wondering about. So
Great question.
Anything else on this issue?
Okay. So we have one more set of non-pairings. These are not substance use disorder. These are the ones that are more ADHD, anxiety, etc. Jason, you're bringing it up. Thank you.
Yeah.
So for ADHD, there was a question about medical team conference with healthcare professionals, but family not present. That's on a lot of lines, including a lot of behavioral health lines. Does anyone have any insight into?
So I think this is a question. When you read the statement, it says patient and or family not present. So it's an interdisciplinary team, like a case management or
Right.
a case team meeting. But it does require participation by a physician. So it's an interesting set. It's an interesting code. That's not one. There are typically not a lot of psychiatric providers available for interdisciplinary team, but it seems to have merit. If it's everywhere else, why not on line 121?
And if I can add to that, this has been a huge field for kids with for services where we're trying to find the right prescriptions and having different impacts and effects and not having enough prescribers. And so when we go to have the pediatrician or the physician present and allowing them to do interdisciplinary consultation, so that they can remain the provider and keep that service going, but feel more secure in their plan. I'm in full favor of that because that's something where it's going to be short. It's going to be to make sure that services are on track and that they have the information that they need to be able to keep serving a patient. So for me, that made sense because that's not consultation for like, hey, how are things going? What's the update? Where is everybody at? That's usually when people are like, where do we want to go as a health team for this patient? So it made sense to me to have it covered. And I think it would actually kind of maybe help physicians take on the roles where there's deficits in psychiatric prescribers, especially for youth.
Okay, great. So that sounds like
I agree with that. I actually have a question related to that, specifically related to children. If a physician was present at an IEP meeting regarding the child who has ADHD, is that paid for by Medicaid?
I have no idea.
Well, it sounds like it wouldn't be in the current state unless you could build this CPT code, because that would have to be a concern.
Yeah, and as somebody who has been, so I'm a psychologist, but I will go to IP meetings and sometimes it's covered and it's not. I can't imagine that being covered because it's an educational service and it's a request for team members to be present versus a medical service. So I can't imagine that being covered unless there was some kind of prior authorization and need to have some kind of link to medical care.
Yeah, I was thinking if it
being
was an IEP that
that
involved like a really medically fragile kiddo that
Yeah.
needed certain medical like protocols written out for like if they have a seizure, do this, if they have whatever. But yeah.
But it does say
I can
medical
also
team. Sorry.
Yeah. So if it was something where it was like, we need to have the medical team and the school team come together. We happen to be having an IEP meeting next Friday from 9 to 11. Can you come for the first half hour? We'll focus on that and have the medical part, and then we'll move on and incorporate the IEP. I can totally see that happens in my field, but I can't see it happening as just like the physician attending the IEP.
Yeah, I think you'd have to have the rest of what's considered the child's medical team available, which might be behavioral health staff.
Okay, thank you for clarifying that. I wasn't clear about it, but thank you.
Yeah, I think the phrase medical team conference is is a part of it.
Yeah, and when I typically think of when I think of a medical team conference would be like in the inpatient setting, you might be getting everyone together for like a, global planning. They do that a lot in like cancer. In the outpatient setting, I could see the primary care doctor talking to their psychiatrist with like a nurse manager present, and they're all, I mean, that's kind of what I would think a medical team conference would be.
Well, I would add the integrated psychologist or social work,
Yep.
like and it may be the dietitian because there are some eating, you could get the whole team together. That would be good.
Like, we want to add this one. Some
Yeah, I think
questions
that's a
about the
yes.
details. Okay.
And then we kept seeing this prolonged outpatient evaluation. It's on almost every line. We're missing it for ADHD and anxiety. I could possibly see where you might need that. Anyone object to us adding that?
I'm in favor of it. I was curious about what is the maximum of the primary service? Like how many minutes do you get? And so when would the extra?
I think it's an hour.
So it says list separately in addition to 99205, 99215, or 99483.
It's your particularly medical codes.
All the time it is driven by the prescriber, or not the prescriber, the clinician needing more information. So that's not something that the client is doing or bringing to, unless, but yeah, I think it's because the clinician needs more time to figure out what they're evaluating. So I'm in favor of it.
Great. And then there were a whole bunch of psychotherapy code requests for our eating disorders of infancy and childhood line. Currently, we only have like family therapy on that line. It seemed like it might be reasonable if it was an older child. Let me pull up the line and see what the diagnoses are.
What age group is that diagnosis limited to? Childhood going up to what?
So the Here's the diagnoses. It'd probably be.
I mean, I'm guessing it would be from 0 to 17 with that.
May or may not be
This is-
R6331.
I mean, these aren't eating disorders in older kids. That's just not this
No,
line.
they're not eating disorders. No, they're definitely distinct from that.
Yes.
I was doing some in reviewing the materials. I was looking through this, and there is a lot of psychosocial issues that come with this they're directly related to some of these diagnoses. So yes, most often you'll have a speech or an occupational therapist doing feeding therapy or doing some kind of behavioral implementation plan or something, but there's a lot of increased family stress, of difficulties with social situations at all kind of levels, depending on the kiddo, the age. There can be a lot of impact on the parent-child relationship and attachment related to these. So for me, it makes complete sense that having family therapy and or individual therapy linked to it, because it's not attachment issues otherwise or high conflict otherwise. It's directly linked to feeding and elimination. There could just be so much psychosocial stress that comes from that. So it made sense to me to have those approved.
I'm sorry to jump in just for a second. We have someone waiting in the waiting room. Could somebody let her
Oh,
in?
thank you.
Okay. So it sounds like people are in favor of adding more psychotherapy codes to that line.
Are you okay with that, Linnea? Does that make sense to you?
I'm just trying to look at the list again. I'm thinking so. Not that I mean I got the diagnostic one, so
Okay.
that's fine. And it is correct that it's 0 to 17. I think it's the question of, well, because the codes are limited to a certain type of practitioner, I think it would be fine. I think we're much more aware of feeding and eating disorders in children, much clearer. But often there's a comorbidity. There's often is it a symptom or is it the primary thing? But I think we would err on the side of keeping these open. I think there are places like Clementine and other places where kiddos are going where they need some individual psychotherapy, other kinds of places that are delivering care to our kids. So I don't see a reason to limit them.
Okay, great. Okay, so this one we have codes for collaborative care models. Should they be ancillary or should they be limited in some way? Basically, are there any conditions they shouldn't be covered for?
So I think originally collaborative care was designed and evidence-based around about 5 diagnoses, which is a part of why I think it was limited. Some of the subsequent work of the Ames Center and University of Washington is expanding those diagnoses, but we don't have evidence that for all diagnoses that it's the way to go. I don't think we have a psychiatric provider who does collaborative care on this conversation.
So don't make any changes to what we currently have.
Well, it's currently on 500 lines and then ancillary. Are you saying we should restrict it?
No, I don't think we should. So I see the question is any conditions that should not be covered. I think the barn door is already open on this one. I would just leave it where it is.
It is. These codes are not on the fee schedule, as I understand it. So I'm guessing they're not getting used because it would need kind of a an agreement or a business setup as well.
There's a bunch of things that go behind this, and I believe Medicare does cover
Right.
these, so that conversation is not a part of this one, but typically a lot of collaborative care work is done in primary care and not in a behavioral health clinic. So I think that's a part of it too. So
just leave well enough alone unless there's a good reason to make a change.
Kathy, Yvonne, others comments?
I'm not knowledgeable about the model.
Okay. This is the psychiatric collaborative care model where you have a psychiatrist and there's a care manager, and the manager is screening using screeners, and then the psychiatrist looks at what the care manager has put together, and then they collaborate to make decisions around what kind of care plan for the patient.
Wow, CMS has 12 pages of rules about this.
Yeah.
Our organization has a psychiatrist, but we do not have a care coordinator where they are a team collaborating to determine care going forward.
And that's a part of there is this other question about, so collaborative care model is a very specific kind of model. There is this other question about asynchronous consultation, and which is, I think, a part of what maybe you're describing. And there are some consultation codes, but those also are not typical. They're not open right now. So there's a whole nother set of questions, I think, that goes with this. But yeah, there's a lot of there's a lot of work that's been done, but it was done in a single academic medical center to set this up. So it has its pros and cons, is all I'll say.
I've implemented several primary care clinics with psychiatric consultation, including the care coordinator embedded in the primary care. And I can tell you it's been incredibly useful. And if we have opportunity to expand, I would recommend.
Yeah, and I think what we're saying is the question was, should we not cover that? That's actually the question here. So thanks, Ryan. The question was, should we change the coverage? And what I'm saying is, I wouldn't suggest that we make any other recommendations, whether it's going to be covered or not on the fee schedule. I think, again, goes back to that comment that Ariel made earlier, that's not a part of our decision making here.
Great. Well, thank you. You guys just went through a lot of codes for me. Just roughly 8 or 10 code changes. So this might actually come to next week's VBBS just as a sort of a consent. These are the changes you all recommend. If we don't get it put together before then it'll come to November. But that's the specifics that we really needed input from you all. Now we're going to give you some information, and then I really wanted your input. This isn't something that we're going to definitely bring something forward with a bunch of recommendations. It's more, Jason's going to do a little, he'll explain the whole benefits update project, and then I have gone out on a limb and drafted what I think might be a future state for the behavioral health lines that are below the line. I wanted to show that to you just so you can kind of get a sense of what might how things might look, and just kind of get a sense, is this the right direction? Is this something, not necessarily all the details, but is the overall plan something that you all feel comfortable with, or do you have other suggestions or input? So I'm going to let Jason kind of give you the background on what this whole benefit update. I'm sure you guys have probably been hearing about this. It's I think it's been percolating out into the CCOs and the provider community a little bit.
Yeah, so thank you, Ariel. As she said, some big changes coming, and I know this may be a lot to digest if you haven't heard it before in another setting. So feel free to stop me if you have questions along the way, and I Actually, no, let's save them till the end because I may answer some of them and then we can just address them at the end. So first of all, in 2022, CMS ended Oregon's waiver related to the prioritized list, and that will take effect 1/1/27. So we've got a couple of years to prepare, but the prioritized, the waiver that allows us to use the prioritized list to essentially not cover services that are a lower priority will end. That said, a lot of the operational elements will continue. We will still have evidence review. We will still have code pairings. We will still have medical necessity guidance in the form of guideline notes. HERC's public processes will continue. So we've got some change. We've got some things that are staying the same, and I'm going to go through a lot of these. So from a legal perspective, and I pardon the legal references, but I think it's a helpful framework to understand the legal requirements. So each state has a state plan that documents its agreement with CMS about leveraging federal funds for its Medicaid program. State plan is very high level on descriptions of categories like physician services. And it says some of those may have PA. It doesn't say which ones. Lab and x-ray services has high level limitations on both mandatory and optional services, but they're very high level. There are two key federal rules. The first one there, 42 CFR 440.230C, says that the state may not, quote, arbitrarily deny or reduce the amount, scope, or duration of a required service because of the diagnosis, type of illness, or condition. And that's what's currently waived. And that's essentially what the prioritized list does. I might disagree with the word arbitrary, but that's what the law says. The other one is in effect and will continue to be in effect. It says the states may place appropriate limits on a service based on such criteria as medical necessity or utilization control procedures. And that will continue to be in place. So what's going away is, quote unquote, arbitrary limits because of the diagnosis, type of illness or condition.
Yeah, and you'll see in my presentation, there's a lot of behavioral health diagnoses that we currently don't have any treatments for because they are below the line.
Right. And so, yeah, we'll get into that. So our current waiver has that language there, talks about the ranking, the prioritization based on clinical and cost effectiveness. That waiver is ending. After January 1, 2027, OHA can't prioritize or deprioritize, more specifically in the form of a list. OHA can continue to place limits on benefits based on medical necessity and can manage utilization. HERC will continue to determine which OAP services are medically necessary. So most of that discussion, all of that discussion was essentially about which services are medically necessary for which condition. So all that discussion will still be needed. CCOs can and should continue to manage the benefits subject to the limitations in the state plan, medical necessity, and the CCO contract. Beginning 1/1/27, again, the waiver is ending. We'll use the state plan, although honestly, you probably won't have to look at that very often because almost everything is in administrative rule. Medical necessity policy and utilization management. We'll still have those things. The state plan will continue to define benefits at a high level. We don't expect many changes there as a result of this project. There may be other things that happen as they always do. HERC and the administrative rules will provide medical necessity policies, just like they do today. Other policies will come from CCOs. I know some CCOs reference external resources in areas where HERC doesn't have anything to say. However, if the service is medically necessary and it fits into the confines of the state plan, Oregon needs to cover that. Some services will still not be covered because they are not medically necessary, or there's some other permissible limitation. We expect, as a result of this, a small increase in the scope of services covered under OHP. So what will go away? The funding line will go away. Remember, we often think of things going in her placing things below the line or deciding not to cover them. Well, technically, it's the legislature that sets the funding line, as I'm sure Kathy and Gary know from the many years, some of the rest of you. The ranking, since there is no legislative funding line, there's no need to rank services. The denials, some of you may remember conduct disorder for children 18 or under. That was a one-time above the line, and then the legislature moved the funding line up. Medical, was it more medically necessary? Did it become less medically necessary? No, it's just the funding. So that kind of thing will no longer be able to happen. The comorbidity rule is based on the funding line. That will also go away. There will be continued need for coverage decisions, denials based on medical necessity and benefit limits. Again, we'll still have our code pairings. All those code pairings we discussed today will still need to decide should they pair with these diagnoses. The guideline notes will continue to support medical necessity decisions. We'll continue with our HERC public, transparent, evidence-based process for decisions about medical necessity. So I want to keep the good of this 30-year process, even some of the best parts, at least in my opinion, keep those even as the structure of the prioritized list itself changes. This is a high-level overview of the services addressed by the prioritized list. I apologize. This was developed for other settings and it doesn't have behavioral health listed, but it's there. There are actually quite a few rules in the state plan about behavioral health, but they're about which type of providers do what and so forth, and it doesn't usually get into that. This is a rather busy slide. But it talks about, you see on the left side, the current structure with the prioritized list. We've got the funded region, the unfunded region, and then alongside the funded condition, the ancillary services. And some of those have guideline notes. Then there's non-pairings for funded conditions. And those are things might not be considered, somebody might order for a funded condition, but might not be medically necessary in most cases. There are also unfunded services, again, like the conduct disorder was a couple of years ago. HERC, and we'll look for your help with this. We'll need to review all those unfunded lines and say, what's medically necessary in that universe? If so, we'll need to find a way to cover it. We may need to add some utilization management policy. If not, it'll either need to be excluded in the state plan if it's an optional service, or we'll have a medical necessity policy saying that it's not medically necessary. Staff are reviewing the unfunded region. Ariel has been doing a tremendous amount of work, as she always is, but I think even quite a bit more. Some conditions only need office visits, medications, emergency services. Those are below the line technically, but from a realistic perspective, I think most OHP patients are getting those conditions covered, those services covered. Others already have guideline notes that will say what is and isn't medically necessary for those, and we'll review those to make sure they're accurate and up to date. Others will require analysis, which treatments are medically necessary for these conditions, and that's what Ariel's about to ask you about. For prescription drugs, which are, of course, a component of treatment for many, many conditions, any criteria that specifically references the funding line or unfunding conditions or the prioritized list will need to be changed. And another reason will need to be given. Often it will be that it is not medically necessary according to your policy. We expect for dental, we expect the current limitations on crowns, root canals, and dentures to be unchanged. That's an optional service. So we would need appropriation to expand those limitations. Those services, by the way, for those of you who may not know, are in the funded region that were cut back in 2012 due to the budget crisis coming out of the housing crisis at that time. We do expect a budget impact related to some of this. Our rates will be actuarially sound and will follow the usual rate making process. That's a little reassurance from any of you affiliated with CCOs. HERC will continue to make decisions very much as it does today. The names of some committees might change, but we're expecting more or less a similar scope of services to what we do today. This is a high-level overview of the plan for the project. You can see there in the middle, the HERC public meetings will start probably, well, I mean, this is honestly the first we've talked about it in any detail. So you all are inaugural, but it probably begin at the November HERC meeting for the commission itself. There are a lot of other things going. There's operational details to change all those denial messages, communication materials, raise awareness of the newly covered services, public comment, community input from CCOs, but also the likely to be a public meeting this fall for members. We've already been meeting with some member representatives. So that is, I'm not going to go through all this, but we are doing comprehensive planning for this. There will be, again, for the CCOs and open card contractors, another meeting in November. We've had 2 already. There will be a CCO work group, an anticipated public meeting, and then there'll be continued updates, both at our HERC public meetings, at which any of you are welcome, and our quality and health outcome committee meetings, which are also open to the public. So with that, and normally you all, if you have concerns, email us at our herc.info email address. They ask if it's related to this, that you send it to that 1115 waiver.renewal at dhsoha.oregon.gov address, and I'll post that in the chat in a minute here. There's also a benefit update project webpage. So with that, what questions do you have? I can imagine there are some.
Shock and awe, Jason.
Yeah, I know. Everybody's taking it in. And if you don't have any today, we can follow up later. We could also just dive into some of the details. But let's just give another minute for people to.
I know that this is far out, so there's probably not like a specific answer or thoughts around yet. But and this idea of like moving from the prioritized list to just medical necessity, and even for the diagnoses that we currently have, we're identifying medical necessity and functional impairment, things like that for our families. Do we think there's going to be an increase in what is required in identifying medical necessity, especially for things that were previously unfunded? Or
So I think, and this is all a process in development, that medical necessity is mostly going to still be code pairings. We're not going to have lines the way you all are used to seeing them. There's probably going to be more like big code groupings. So like today we talked a little bit about substance use disorder, and then there's a couple lines with like mood and substance use. Those might all get condensed down. And anything in that diagnosis universe it'll be medically necessary to do any of those services in the code universe. There will be some things that will have guidelines. For example, cholecystectomy, taking out a gallbladder. We already have a guideline about when it's medically necessary and when it's not. So that will still be there.
Our transcranial magnetic stimulation guideline, I would expect that will be a straightforward conversion to a medical necessity policy.
Right.
And if there's any new evidence discovered along the way, then we'll update it while we're doing it.
But let's say you are a clinical therapist and you are doing therapy with a client. You don't have to prove that it's medically necessary. You just have to say, my patient has severe depression and I did psychotherapy and medication management, and that will be all.
No new paperwork, I don't think. For the unfunded conditions, they wouldn't be covered today. There may be some new opportunities to serve patients that you didn't have before, and that's part of what we'll discuss with this group when the time is right.
Gotcha.
Yeah, and a lot of the behavioral health realm, because it's sort of office, most of it won't really change, other than, as Jason was mentioning, some of the below the line diagnoses that aren't currently available for billing may become available.
Mm.
I think where you might have to prove medical necessities more like in the surgical world or like an MRI of a brain, kind of what you already see nowadays with commercial insurance. Like, tell me why you want a brain MRI. Like,
Right.
So I'm thinking a lot of it will be under the hood from the member's perspective or inside the black box of how we do things. But some of the denials, again, I heard somebody say today, well, today we just tell somebody it's outside the benefit package and it's not covered. Tomorrow we're going to have to tell them it's not medically necessary, not covered. That may be a harder message for people to receive in some cases. Um, in other cases, there are services that are being denied today because of the funding line, and they will be covered. And so that'll be a good news. And again, it'll be largely those conditions that are in the unfunded region.
Gingrich or Jason, for us old timers, what was the objection at CMS to the prioritized list? What's the philosophical reason for the shift?
So there were some calls that I wasn't invited to. So I don't know all of the things. I know there were concerns that, this is 1115 waivers are typically for innovation. It's been 30 years. Is that innovation anymore? Should it be just normalized? I think there were some concerns from some advocates for patients that certain important services weren't being covered. But again, there were discussions I wasn't a part of, and I'm not sure I'd be at liberty to share if I was. But I know there were negotiations, and I know CMS said, OHA, you need to do this.
and if anybody can explain CMS to us, please do, in general.
We'd welcome that. All right, if there's no other questions, let's go into that other document and get Ariel.
Yeah, so as
the help
Jason
she
said, you
needs.
all are the inaugural group. Well, technically, I've talked to a bunch of allergists and I've come up with allergy stuff, but nobody in public has seen it yet. This is the first time in a public meeting that we're really talking about what we are really going to need to do. So I have looked at all of the lines that are currently below the line. So their diagnoses on them are not funded. Typically, the procedures are, because the procedures are office visits, they are psychotherapy, they are, all those HCPC codes with like behavior, peer support or whatever that we have previously talked about. So what we're really, for the behavioral health lines, what we're really talking about is really the diagnoses. There are many, many, many behavioral health lines below the funding line. Some of them, if you look at them, you'll kind of say like that, that's interesting. Why? And there has been over the years, lines have had strange bedfellows put together. So there may be a couple things together on a line that don't make sense together. And like for some, and one of the lines particularly, there were things that definitely need psychotherapy and things that definitely don't need psychotherapy. Interesting. So this is a test project. I went ahead and just as just a starting for a baseline, all psychiatric diagnostic evaluations are diagnostic. So um, if there's if you're not sure what's going on, you're seeing someone for the first time, whatever, all of those that's going to be continued to be covered no matter what. So I was really looking at the below the line. I kind of took the diagnoses on all of the behavioral health lines and lumped them into two groups. It's kind of how to think about it. One of them is going to be things that really don't need behavioral health or psychotherapy. They just need perhaps a primary care office visit. And then there are some things that we have reviewed over and over again in the past and have come up with the fact that there is no treatment, or people don't want treatment who have these things. So, they might not pair with psychotherapy. And then there was a second universe of diagnoses that I thought would benefit from being in we're not calling them a line anymore, it'd be like a code grouping that would have the psychotherapy. So in the medical only, so you would have office visits and you would have maybe medications available if they're not PA'd. Most of the paraphilias, like sadomasochism, fetishism, I mean, none of those, we've talked in the past, none of them seemed that these would be anything that would really respond well to psychotherapy. I know pedophilia frequently has court-ordered therapy, but we can't cover that by law. There's a sexual dysfunction line, and we've been asked to look at a couple of conditions. There's a few like female sexual dysfunction and dyspareunia, those types of things that might benefit from psychotherapy. We've heard from like some of our gynecologist colleagues. On the fibromyalgia line, there are chronic pain diagnoses that definitely need psychotherapy types of things, but then there's things like fibromyalgia and chronic fatigue that we've reviewed, and psychotherapy is not helpful for them, although PTOT might be. Impulse disorders, like kleptomania, pyromania, do these things need psychotherapy, or would they just be on sort of a medical only line? Same with factitious disorder and hypochondriasis. Most of the personality disorders we have talked about in the past, they don't really respond well. But some of them might benefit. So we would have to look through, like, would schizoid personality disorder benefit from psychotherapy? Perhaps. Narcissistic personality disorder, probably not, but, should it be offered? There's an abuse of non-addictive substances. That line just didn't really make any sense to me. It almost seemed more like an eating disorder line, not really it doesn't really need psychotherapy. And same with pica in adults. That just needs more like testing to see if you're iron deficient. And then there are these staff affectionately call them the dump lines, but they're like the no effective treatment line. There's one for mental disorders. And this includes like uncomplicated substance use. So I drink a glass of wine when I go out with my girlfriends once a month. That's uncomplicated alcohol use. So that most people would not think that would need treatment. And then there are some neuroses and occupational neuroses, including writer's cramp was one of them. And then like academic underachievement, misery and unhappiness of childhood. I thought that sounded awful, but I think that might just need other interventions other than medical care. And then that's the group, like I said, we're not, what I'm really trying to get feedback from you all is this the way to kind of look at it? And broad things like, oh no, you got this wrong in a few areas. We're not going to go through like every single diagnosis and say like, oh, this is what we should do today. I'm really looking more for a, like more of a, not a 10,000 foot, but maybe 1,000 foot view. So the second code group were things that I thought psychotherapy might be helpful for. This would include a couple of female sexual disorder conditions that our gynecology colleagues have spoken to us about. Chronic pain, which the Pain Commission has been quite clear that this is very helpful in all of their research. Vaginismus goes with that, sexual dysfunction. Things like conversion disorder, somatization disorder, somatoform disorder, those might benefit. And then at the very bottom, if you go down just a teeny bit more, you'll see. So I made this look a little bit more like what you're used to. It's a line with ICD-10 and CPT codes. I think maybe we're going to call them code groups. So don't say this is, oh, you called it line, whatever. We are we are evolving as we're working through this on kind of what this will end up looking like. But even if we call it a code group, you can see it looks very similar to our current lines. I suspect these code groups will end up being much, much larger over a few years than our current lines, because we'll probably put all conditions that just need medical visits on a line. I might end up putting, I think when I've talked to the ophthalmologist, there may end up only being 5 or 6 ophthalmology groups, like retina and other like major body part things. So I could envision at some point in the future, once we're done with the below the line and we start looking at above the line, there might be a single line for substance use disorder, a single line for conditions that are requiring psychotherapy, and then, a medical only line kind of thing, or code group, whatever we call them. So that's just kind of spitting out a whole bunch of stuff in front of you all. I would love to hear your thoughts, your any input, direction, questions, things.
I could just add one thing, Ariel. I'm curious too, like what kind of things we should make sure we don't pair.
Yeah.
Because that will become important, because as we consolidate things, there'll be a tendency to standardize. But if there's a case where, a pairing would be wasteful or harmful, that's
Right. We had gone through with this group a year or two ago, perpetrators of domestic violence, like treating them actually increases the rate of domestic violence. So we don't want to do that. But yeah, that's a great example, Jason. Thank you for calling that out.
again.
I think for some of us who've been at this for a really long time, it's just going to take us a little bit of time to kind of wrap our heads around.
You can go through the stages of grief. That's fine.
Well, it's actually not that. I mean, we're also a dynamic field. And so the things that we might have said historically, like before DBT was a thing that really began to be effective with some of the personality styles and disorders. I mean, there's going to need to be some review and marrying up of those kinds of things. And so I think it's a much more complex question than are you going to give us a thumbs up or a thumbs down right now?
No, I'm not looking for a thumbs up or a thumbs down. What I'm really looking for is just that. So,
questions, principles that we should think about. Yeah, that kind of thing.
I do think that the opportunity to do some pairing with some evidence-based practices and things, I think that's a part of what we miss in the nuance of this. It's like, is it completely open code and you can do anything you want? Or is there an evidence-based practice tied to that particular diagnosis and or CPT code, that kind of thing? I think there's just potentially another dimension to consider.
So are you saying, let's pick on schizoid personality disorder. Would we want to maybe write a guideline that we should, I'm completely making this up, but this type of disorder should only be treated for 3 visits, or it should not, it should only have DBT, or would it be a little bit further out and just looking at like, is there evidence that psychotherapy in whatever form is helpful?
Or just even a more generalized statement that an evidence-based treatment needs to be utilized when treating this condition. That's a hard one because evidence-based guidelines are often they're kind of biased because it's who got funded. So it makes it a little bit, I'm just kind of stepping back a moment. So I'm going to argue both sides of that. But I also think that there are certain things that, talk therapy alone isn't the only thing that's going to treat. We don't see a generalized progression. So for certain conditions. So I think that there are certain things that are We may have some work to do around, are we bringing evidence or information or guidelines, information to our guideline notes? And that's going to be heavy lift. But I think maybe it's a different, maybe that's the pivot.
Yeah, and just the other thing I hope you picked out from Jason's slides is that this lift has to be done in a year, maybe a year and a half.
So, Errol, so it sounds like the fallback position for some things where we think there's no effective treatment is to cover medical visits only.
Yes.
And what does that mean? Does that mean you can see a primary care physician and they can bill that code? I mean,
Yeah,
what does
but
that
that's
mean?
basically the status quo. So essentially office visits, the 99213 at your primary care provider is considered diagnostic in the system. So um, you could go to your primary care doctor for fibromyalgia once a month and they're getting paid for that visit, even though fibromyalgia is below the line.
And you could get those, it's very much the same way you could get these psychiatric assessment codes done. Hey, hey doc, I'm really worried, I'm stressed out. And it takes 2 or 3 visits to figure out what that stress is. Is that an adjustment disorder? Is that something else? So that, and if there are no medically necessary treatments for that condition, then we wouldn't cover beyond that.
Yeah,
Honestly,
and
if CCOs don't see a risk of a lot of waste, they may not even ask those questions. I don't know how that works.
yeah, so many of the things that are below the line now will end up being in this medical visit only, which is, like I said, it is kind of like the status quo. You could go to your primary care doctor, they could bill whatever they feel is, they could bill narcissistic personality disorder. We would pay them, but we wouldn't pay them a psychotherapy code. We would only pay them the office visit. You also can prescribe medications as long as there's no PA, a prior authorization. Um, like if you were prescribing an SSRI for something somatoform disorder, it's probably getting paid for, even though technically, if you look at the literature, it might not be effective because nobody is looking to see like why, tell me why you want fluoxetine for this patient. They're just filling the prescription. So yes, I think Kathy, just to go back to your original question, the default fallback will be a medical visit only line, which will be I suppose if you had what we're hoping for with a true medical home might include some behavioral health, but essentially it would just be more of an evaluation visit.
It's really status quo because those that's currently available today. That's exactly what happens today.
Right. And with an integrated medical home, you'd have some ability to manage things that we know aren't really, quote, treatable with the therapies we've got, but it lets a physician and their staff manage it. Okay. Manage whatever's presenting, basically.
So I'm guessing you'll have thoughts arise in the middle of the night, next week, next month, when you talk to colleagues. Please send them our way early and often, because the more we know about what you're facing or what your ideas are, the better job we can do making this a smooth transition and good for our members.
Yeah. And thinking specifically about behavioral health, I know this group tends to meet 1 to 2 times a year. I anticipate that we might meet more often in the next year because we'll have to do some of the nitty gritty. We'll have to drill down a little bit. We could take it in many different ways. Which diagnoses need a certain treatment. We also may end up looking The earlier discussion kind of was striking to me because there's a lot of these HCPCS codes that are peer support or whatever. We also could kind of go at it from that direction. So peer support should be provided for what conditions? I don't think that like outpatient intensive rehab should be covered for non-psychoactive, like the people who are like the laxative abuse. There's actually some like residential therapies codes on that line, which I'm glad we're not paying for right now, because I think if you're abusing laxatives or whatever, it's probably well, I guess that could be a eating disorder, but so start thinking about whether what would be the most useful way to look at this. Would it be most useful to kind of look at, we could go through line by line, kind of pull apart what are the different diagnoses on this line, what are the different treatments, do these diagnoses, like I said, some lines are a little bit of a Frankenstein. They're kind of sewn together where some things need psychotherapy, some things need some other type of therapy, but they ended up on the same line because of historical reasons. So separating those out again.
It seems like it might make some sense to cut out the easy stuff first. Like to take there are a whole lot of behavioral health diagnoses that have all the same codes on them already. And what you want to pay attention to are the things that should be different.
Right. Yeah, and we can do that through data analysis and bring the kind of the things that are different before you.
So Kathy, are you saying that a lot of the things that are currently paired with psychotherapy, but we don't pay for right now, we should?
No, the ones that we do the current, I'm talking about the covered portion of the list, because we need to redo that whole section too, right?
No, I mean, we do eventually, we will. Before 2027, I think the only thing that we're really going to get through is the below the line.
Okay, so the below the line. Okay,
yeah.
So that's okay. What I was thinking of the covered portion of the list. Okay.
And yeah, like we may do some consolidation like what you're thinking about, but we got to meet our deadline first. And the way we're thinking about it, since we're going to be using the same format of files, if we don't have to touch that funded region, that'll simplify things to some degree.
Yeah.
But again, we'll look for opportunities to streamline.
I've met with a couple specialty groups just to initiate kind of looking at their lines, and both of those meetings ended up with covered lines being pulled in because the list was an arbitrary thing, and so trying to make it more reflect actual practice. So when I say we have to focus below the line, I'm not saying that we're not going to also have some issues with things above the line. And Kathy, you had said to kind of start with the easy things. Do you see anything in the current below the lines that are like just easy?
No. Unless it may be easy to pluck out. I mean, we will have to look at the detail of which diagnoses are in each line, but it may be pretty easy to see which are the ones for which we think there is no effective treatment still. And then sort out which ones do we need to do at least a mini evidence review, and what do we think should be covered in some way. And then you've got to write guidelines. It's a huge piece of work.
Mm-hmm.
And I want to level set a little bit because this is such a big piece of work. We may not have in-depth evidence reviews on a lot of things unless there's some, specific questions or concerns. Some of it we may just rely on our experts and then fix things later.
Yeah.
Yeah, I guess the other thing is if there's not a concern about waste or inappropriate harmful care, then we might just default to covering some things, and then add criteria as we need to address any concerns.
So one thing to think about is, are there advocates that are wanting us to add specific services? And are those ones that need more careful thought and review?
The fibromyalgia and chronic pain folks are the ones I'm thinking of.
I'm thinking the gynecology folks too that came and talked to us.
Yeah. So those we probably need to pay attention to.
Gary?
Yeah, kind of along that same lines, just my experience, and I think we all know this, that any major changes to a system like this, how is it going to affect our communities of color out of the gate? And I think it's really important for us to be mindful of this, because already we have a system that has a lot of disparities towards our BIPOC community. So I want us to be mindful of that and be really, I'm certainly going to reach out to those advocates on the outside of this to see how they're feeling about it. Because frankly, this deal, I'm pretty dialed in. It's first I'm heard of this change coming out of CMS. So
yeah, Gary, as you do that, and I think that would be wonderful because that's top of our mind as well. But one key message as you talk about it is the plan is not to take any benefits. There should be no reduction in services. This should be only adding services and, then some changing under the hood. But if there are ways that any of this change could harm people or help, we should know about that so we can do the best job we can to address any disparities.
I agree with Gary because there are such significant biases and who was excluded from studies and who was excluded from evidence. And, we do things when we select subjects and, again, the academic environment is not all inclusive. You don't get a lot of rural subjects or people who live in impoverished areas. So I do think there is merit to the risk of perpetuating bias in what we put together. So I appreciate Gary you calling that out.
I guess what jumped out is that I consult with a Native American organization, and a lot of the folks are on open card. And then also think about how this may affect the tribal communities and, which I didn't see that mentioned anywhere in this. So just
We
have
have
to see how.
regular mandated consultations with the tribes. I think there's a plan to keep them updated, but definitely that is an important group, just like all the other communities we serve, that we need to keep in mind.
Yeah, I don't expect there to be any different changes for tribes than anybody else, but we do have a member of there's a tribal member, and hopefully he'll make us aware of things. And yes, if you hear of things, then please talk to those who in the different communities, because we can't have feet on the ground everywhere, and that's why one of the reasons we appreciate this group.
Yeah, and also as you all go out and talk to colleagues or people you're working with or people you're serving and if you talk about this and they raise concerns or questions, and please forward those to us. We'd be happy to be made aware.
I guess while I'm kind of at it, I'm thinking about the awesome thing that we've advocated for over the years, and having CMS authorize us to sign people up that are incarcerated. So starting on January 1st, so folks coming out of prison can sign up for the health plan, and I'm hoping that doesn't get affected going forward. I don't see how it is because this spoke to the prioritized list, but
no, I have been working just very sort of peripherally with that project. They're actually going to get some OHP benefits within the last 3 months that they're incarcerated. And it is going to be a more limited benefit package because of the but we've been trying to build a pretty robust, like a complete dental evaluation, a complete mental health evaluation, a complete physical health evaluation. But yeah, this shouldn't affect. I would assume that population will, yeah, they should hopefully benefit from this.
Yeah, and the plan, no reduction in benefit services, but also no reduction in who's covered. The plan is for this. I'm hoping nobody loses access to services as a result.
Yeah, that's great. And, I just, along that same line, it's not clear yet who the DOC is going to allow, like community-based organizations to go in, sign people up, and maybe do an intake. It'd be great if we can have some leverage as the HERC system to say, allow some more authorization for community-based organizations, because the process is everybody has to do a background check. The state police do those background checks, and they exclude a lot of people. So that may default the system into having DOC employees or other state employees doing this. And that could just be a machine that's just kind of not spending the appropriate amount of time with people that's signing them up and checking boxes. So there's a little bit of work that needs to be done in this.
Yeah, and the HERC's actually not involved. I'm very peripherally involved. I was just helping them find codes and things for what I think this is they have a coordinator. I am blanking on her name, but they have a coordinator who's working on this. And
I'm just seeing Adrian's chat here. Are there other states that have already taken this approach? If yes, do they have lists already? So the short answer is there's only one prioritized list in the world, and in Oregon, and so all the other states are doing more or less. They've been doing what we're about to need to do, although they do it in different ways. They don't have as much of a public process in most cases. So we'll still be unique in some ways, but the fundamental rules, those federal regulations that I referenced in that presentation, will apply to Oregon just as they do to 49 other states as well as territories and so forth.
But that does mean that there may be some guidelines in existence that for some of these conditions that we've got to rethink.
Yeah, and we often will look at guidance from what other states are doing, Washington or New York, or even private payers as we develop things.
yeah, that is most other states, most private payers have a very different setup. So converting ours to their setup is a process.
Yeah.
But as Jason was mentioning, one of the things that we've gotten a commitment on is that the HERC will still continue to be open, public. People can contact us. They can listen to decisions being made, have input. And we're going to incorporate evidence as much as feasible as we make these changes.
I guess I want to say to the staff, it seems like a major change after all the years that you've also invested in doing it the way we do. So my sympathy and appreciation for the flexibility that's going to be required to make it through this next iteration.
Yes, thank you. It is kind of I've likened it to the ground shifting under our feet. At the same time, anytime in our healthcare system, it's complicated enough anywhere, and the prioritized list is kind of a unique piece that sometimes I know has posed a barrier to care our members need. Like anything, pros and cons, but I'm hoping we can do this in a way that will benefit our members.
Well, and if you can keep the values about transparency and use of evidence and that kind of thing, that's holding on to the core of what we've got.
Mm-hmm. Yeah, I remember going to a conference and sitting next to a medical director from another state and described what HERC does. And she said, "Oh, I just make all those decisions." And I thought, oh, that'd be a lot easier, wouldn't it?
Yeah.
That was different for me, Jason. I actually went to an ethics meeting in another state, and they talked about how evil the prioritized list was because it was rationing healthcare. And it was a really uncomfortable situation to try to sit there as a HERC member and think, like, how do I explain that what we did was we allowed more people to be covered? Like, the premise of it was to not restrict care, but to create a way where more people could have access to basic health care. So it is interesting how people frame what the value was or wasn't. But
Right.
I do think we have moved a long way in the last couple of decades. And so this will be just another interesting move. But I do worry that as we move forward, we may end up shrinking the pool of people who have access to care because the financial burden becomes too much for us. It's a risk.
It is. We've moved from, I think, 15% uninsured in those days, late 80s, to I think around 3% today, I heard recently. So much progress on that front, and hopefully we don't go backwards there. Thank you all. This has been very helpful. And as I said, if you have thoughts or questions that arise in the coming weeks, please send them our way. And we will do our best to answer them or change how we do things if appropriate. And expect we'll probably be having a meeting before this time next year, well before this time to dig into some of these issues.
Yeah, what I kind of had as a thought in my head was probably starting in the winter, in January or February. We'll probably have a first meeting to sort of make sure we have a game plan and maybe start chipping away at it.
Okay, anything else before we close?
Thank you all again for sharing your time and your expertise. Just to bring things to a close, the coding changes that you all suggested, like I said, will probably just come next week. I think I can put them together quickly enough. They can be a handout. And you're welcome to come to the October BBS and HERC meetings if you want to. And that would be next Thursday. They are online or down in Wilsonville, the Clackamas Community Training Center. And then our next HERC meeting after that is November 14th.
14th.
So, yeah.
And for those of you who don't know, I am actually a member. I am a HERC commissioner, and on the chair of the EGBS. So the messages get carried forward; they're not separate.
Yes,
it's not just
yes,
the staff.
and thank you for being that conduit, Linnea.
Sure.
All right, and Jason popped the waiver renewal email for specific questions. And then things, especially if like you're taking a shower tomorrow morning and you have a brilliant plan for how to reorganize all the below the line behavioral health lines, drop me a line. But you will definitely be hearing from us as we start to gear up. We'll pull together. I would probably think we'll meet like 3 times or more next year. So hopefully you all are okay with with that. Obviously, we are very appreciative of any of the time that you can give us.
And I want to also say I really value the continuity of folks who keep hopping on, because it's really hard to like reframe it each time. So really would love to have everybody who's here stay at the table, because it's always a little bit interesting to try to explain it again. And we may not have that luxury given the pace we are going to undertake.
Yeah, it's true. I'm glad we have so many members who joined what was it, a year or two ago, and also some old hands from many years. So it's great. This is a great mix.
Yeah.
All right. Have a great afternoon, everyone, and we'll be in touch.